So, good afternoon, everyone. I am Montress Lucas with NephCure. I've been with NephCure a little over 2.5 years, and I am so excited to present to you our first annual FSGS Awareness Day. This is our first, hopefully, first of many annual town halls that not only bring awareness to FSGS, but also, hopefully, as they continue to grow and time moves on, even more treatments are available and clinical trials are available. But today kicks off our first annual town hall. I was just telling our amazing Dr. Campbell that this is the first, they're all town hall I've done, probably over 11 or 12 of them in the last 2 years. This is the most registered for town hall that I've ever seen, with almost 180 people registered. So it's super exciting. We are so honored that so many of you all have joined us this evening. To start us out, I'll go through the natural flow of how this will go. I'll start out by first interviewing Dr. Rastogi and Dr. Campbell. I will usually say, wait for your questions at the end, but we all know that's not going to work. Let's make this interactive as possible. So as you have questions, please put them in the chat. If they're very personal to your own your clinicals and your labs, I ask that you refrain from doing that and instead email us at NephCure. My email is here now in the chat. Thanks, Kevin. That's my email. So if you have any personal questions in regards to sorry, let me send it to everyone. Any personal questions in regard to your own clinicals, I can connect you to a NephCure specialist, most likely in your region or very close to, and get those answered for you in record timing. So please know that if you have any personal questions that are not overarching, we can for sure get you those answers after this town hall. But please, in the interim, feel free to ask any questions in the midtime. Thanks so much, Brittany. Happy FSGS Awareness Day to you as well. But before we start, I really want to first thank our sponsors for their contributing to events like this that allow things like this to even take place. So many of our town halls, we have these sponsors to thank from, but more specifically today, we have Travere Therapeutics, Boehringer Ingelheim, Dimerex, as well as Sanofi, and Apellis. Thank you all so much for all you do to make sure programming like this takes place. We could not do it without you. This is one of the many things that these amazing sponsors sponsor to ensure that our patients get information like the information they're going to get this evening. So thank you all to Travere, Boehringer Ingelheim, Dimerex, Sanofi, as well as Apellis. We could not do it without you. We so appreciate your partnership and your commitment to our patient community. Thank you so much. So now the fun begins. We can start with one of my great friends who I was able to meet at LA Walk a little over a year ago, Dr. Rastogi, who's the chief of nephrology at UCLA. Dr. Rastogi, you want to start by introducing yourself?
Sure, absolutely, Montrez. First of all, thank you so much. It's been just amazing working with NephCure, and I see my dear friend Dr. Campbell over here as well. I just wanted my background. I'm a nephrologist. I'm also a pharmacologist, and involved in FSGS and other GNs. But I think it's when we met, Montrez, it's about kidney health awareness, right? And the support, and there's hope. And I think that's the really key word, is about hope. And I just want to say that thank you so much for everybody who's joining and all the other people who couldn't join. But we march onwards and forward, and we'll fight this disease.
Thank you so much, Dr. Rastogi. Also to highlight, Dr. Rastogi was our keynote speaker at our patient summit this year and blew the roof off the house. I'm so glad I didn't have to follow you. I was so excited that you ended the show because you were incredible. So thank you so much, Dr. Rastogi, for all that you do for us here at NephCure. We're grateful for you. And next, another great friend and also a board member at NephCure who has contributed so much to our movement forward. We would not be where we are probably without you. Dr. Campbell, it's so nice to have you. Thank you so much for joining.
Thanks so much, Montrez. And again, great to see Dr. Rastogi and great colleagues on this call. Thanks for your attention to this condition, which is underdiagnosed and certainly undertreated globally. So really happy that we're seeing some movement finally in the drug development space that's accelerating, and hopes for endpoints that might further expand opportunities for patients with this condition. So really happy to be here. And in my background, I'm also an adult nephrologist at University of Pennsylvania, where I'm the chief of the division.
Also, to highlight Dr. Campbell, he helped me pull off what I think is probably the best screening event we've had at NephCure, and that was at Enon's Men's Tabernacle by another board member, Reverend Miles, who is leading pastor there. We screened 171 men that day and for your analysis, and we are following up with them for services. So thank you so much, Dr. Campbell, for events like that. They really do lend themselves to prevention and also early detection. So thank you so much. So also,
Thank you.
Jamaica Webb. Jamaica's a patient here in Atlanta. She's incredible, newer to our NephCure family, but has made waves already and made such an impression. Jamaica, do you want to introduce yourself?
Yes, good evening, everyone. Like Montrez said, I'm Jamaica, and I'm just here today to talk about my lived experiences with FSGS. So I'm excited and very thankful to be a part of this movement. Thank you.
Thank you, Jamaica. So like I said, we'll start first with Dr. Rastogi and Dr. Campbell with a few questions. I'll prompt a few questions, and if you all have any questions, please put them in the chat. It's going to be interactive. I want you to feel free to add any questions you may have that we can possibly get answered. Please feel free to put them in the chat. And if we run out of time, I will for sure follow up with any questions you may have if you email me, and I'll make sure my email is available also in the chat. So I'll start us out. So just very basic and level setting. Dr. Campbell, what is FSGS, first and foremost?
Yeah, FSGS stands for Focal Segmental Glomerulosclerosis, and again, a pretty complicated term and name, but it's really a pattern of injury that you see on kidney biopsy where the kidneys become scarred, and the scarring happens in patches, right, in the individual filtering units of the kidney. And this can have a number of different underpinnings in terms of etiology and cause. A lot of them are genetic. We have 60 plus genes that have been identified that are associated with FSGS and in a more severe form that leads to nephrotic syndrome. They're immunologic causes, right? The autoimmune reactions. And we're seeing now a number of antibodies that have been identified, like anti-nephrin antibodies associated again with certain types of primary FSGS. Patients with other conditions, right? Like diabetes or hypertension associated disease can have this scarring pattern. So it's really a catch-all description for what you see on kidney biopsy, but unfortunately, it's a major cause of progression towards end-stage kidney disease and a pretty high risk for recurrent disease post-kidney transplant, right? In all comers, about 30 to 40% of patients with FSGS do have a recurrence of disease post-transplant, which can cause that, kidney transplant to fail. In many instances. So we certainly need to raise awareness about this condition, especially because there's no FDA-approved treatment as yet for FSGS. There's hope on the way, but as of this current time, there's no approved therapy.
Thank you, Dr. Campbell, and thank you for highlighting that there's hope on the way. We're excited to talk about that. Dr. Rastogi,
Yeah.
From your perspective, what are the early warning signs of FSGS, especially in communities that are more at risk?
Yeah, so I think Montrez, I think you asked a very important or made an important point about patients at risk, right? I think that's very key. And I just want to piggyback what Dr. Campbell did an amazing job in explaining what FSGS is. So let's go back to that. It is something that we see on a kidney biopsy. This is not a blood test or a urine test or an imaging test. It is on a kidney biopsy. And it's a pattern of injury. That's also important. So it's something that we see when we look under the microscope and staining. The question is what's causing it, and I think that's the next step that we should always look at. It's just an injury pattern, and I think that is important. So if you have a diagnosis, and I think a lot of people who are joining today have a diagnosis of FSGS, we really should try to get to the bottom of that, because if you don't have the right cause that's of FSGS, you will not get the right treatment. And actually, much worse, you can get the wrong treatment, which will have all the adverse events, right? For example, there are conditions with steroids, which are quite often used And Dr. Campbell can comment on that too. And if that's not the right diagnosis and not needed, it can cause a lot of adverse events with no benefit. So I just want to go back that if of everybody who's on the call or have FSGS, when they have the diagnosis, they need to ask a nephrologist, what is causing my FSGS? The FSGS is not the end diagnosis. Now, having said that, the other thing that Dr. Campbell mentioned that I want to reinforce is genetic causes. Now, you mentioned people at risk, right? Who are at risk? Well, if you have a family history of FSG or of kidney disease, forget FSGS, of kidney disease, right? You're on dialysis or on transplant, then there might be a genetic linkage for that. And there are other conditions. I think ApoL1 is going to be very big, and hopefully we'll speak about that a bit today. But there are other conditions like even Alport and Fabry that when they're advanced, they end up with FSGS. So there's genetic causes. We also mentioned antibodies, autoantibodies, immunological causes, diabetes, right? I mean, all those primary FSGS, secondary FSGS, all those things are quite important. So if there's one message you can take home today from today's presentation or meeting is, if you don't have a real cause of your FSGS, go back to your nephrologist or find somebody who is a specialist in that field. And we spoke about that, Montrez, at our wonderful meeting, of NephCure, right? That's
Sure.
the second opinion or the expert opinion, right?
Sure.
So these are situations where we definitely should dive into that.
For sure. Thank you so much. I'm already getting some questions in the chat, which I anticipated. One being, other than genetic causes, how does one test for antibody causes? Do many hear idiopathic collapsible FSGS recurrent?
Yeah.
Either one of you
Dr.
all.
Campbell, do you want to answer that?
Yeah, sure. Yeah. So, right. So, as we mentioned, there are a lot of different contributing causes to this pattern of injury, right? With genetic testing, there are a number of panels and targeted sequencing opportunities available that didn't exist 5 to 10 years ago. In terms of the antibody cause, we don't yet have a commercially available assay, but again, they're being developed, and perhaps in the next few years, we will have some of these antibody panels, particularly for nephrin and other antibodies, hopefully that will be identified. So right now, there are research labs that can test for some of the known or suspected primary immunologic antibody mediated causes of FSGS.
Yeah.
Thank you.
And I
Also,
think the other, and I come to agree with Dr. Campbell said, yeah.
no, go ahead, Dr. Rastogi. I'm just also in the link in the chat. I'm also
Yeah.
putting a link to our genetic testing page in our website. So if you're interested in genetic testing, you can find it there. Go ahead, Dr.
Yeah.
Rastogi.
And I think the other question that just came in, I think I'm just reading the chat, just following up, and this is just lining up with Dr. Campbell said, is what do you see as a meaningful change or progress, right? And in FSGS, there are different things, once again, what's causing it, but proteinuria is still used as a surrogate marker, because at the end, that is causing, the injury that we spoke about is causing leakage of protein in the urine. And at the end, the final result, test is preservation of kidney function that is measured by eGFR. But you just have to keep in mind, sometimes these things can take a bit long if you're looking at endpoints, as was mentioned for trials. But even in your own life, I think being more proactive and at least at the minimum, trying to bring the protein in the urine down as much as you can. That is something, there's one thing the patient should all know, two tests. One is the eGFR and the other is protein in the urine. Those are important markers, and every patient should be very proactive in their care.
Thank you so much, Dr. Rastogi. Definitely agreed. And like I said before, if you have any personal clinical questions about your own labs, please feel free to reach out to me at mlucas@nephcure.org, and I will ensure that you get linked up with a specialist either in your area or that's more than willing to meet with you virtually that can assist with any questions you may have that I can connect you to. Also, if genetic testing has been done and has been negative, could there be an environmental cause such as an environmental toxin? That's from Ramona.
Yeah. Yeah. Dr. Campbell, I can start with that, and
Yeah,
then I would like to hear.
sure.
This is, I think, a very good question, and we just had an advisory board on this as well, and we are actually having a big meeting coming up in September in about genetic testing. So one of the things when you see a test result that's negative, and this is a very important point to keep in mind, if it's negative, you should always keep in mind the test is negative. It doesn't mean that the person might not have that disease, and that's something important. Now, the chances of them having get lower and lower, but it's not zero. And that's where I always say, if the pre-test probability of having a diagnosis is high, then we should look further into it. Just because the test is negative does not mean Natera test, Renasight, we use it at UCLA as standard of care. I mean, or testing for that matter. All my patients are get, but these tests do have limitations. And if the test is still negative, please do speak to your nephrologist or speak to an expert. We spoke about that once again. Montrez had a great discussion about the second versus the expert opinion, right?
For sure.
Find out who in your region is an expert and get their thoughts into that too. And I would love to hear what Dr. Campbell has to say about this.
Please.
No, I completely agree with Dr. Resto again, and I would say as well that Natera and the other panels that are available, again, they're based on what's known about currently identified genes, right? But that consistently gets updated as science advances, as some of these functional studies are undertaken and genetic epidemiologic associations get established. You get an increased number of genes being identified as being associated with or causing, right, FSGS and related conditions. So again, as Dr. Estogi mentioned, pretest probability is high, then it's worth again a closer look. And we often collaborate with our colleagues in medical genetics when there's a question, right, to really define that association. The environmental and some of the comments in the chat related to toxin exposure are important because the genetic risk is not always an independent cause of disease. There are frequent associations between genes and environment and expression of genes rather than their actual coding sequence. And so in terms of getting into those details, it's good to, again, have that discussion with your provider and if necessary, with medical genetics colleagues as a part of a referral.
Thank you so much.
And Montre, just picking back on what Dr. Campbell said, I mean, and picking back on what we discussed at our meeting about the expert and second opinion, this is a classical example with the data coming in left and right. You can't depend upon your busy nephrologist to know everything about these rare conditions. And this will again give an opportunity to get a second and I know, Montrez, you have done a great job in connecting with our providers at UCLA Health and at UPenn with Dr. Campbell, but throughout the country. So that's a great service you provide, that
Thank
connecting.
you.
So use that service. I think that is very important. There's another question that came up, and I think that's important because our time is limited. But the question comes up is what drugs can be used to decrease proteinuria? I think that is very important.
That's a
First
great
of all,
transition for sure.
Yeah. No, and so and if I may answer that,
Sure.
Yeah, sure. Please.
And then so this is actually a very, I mean, the whole kidney space is actually exploding now with data. So it's a very exciting time. And that's what I think when Montrez said about hope, there's a lot of good information coming out. There's a lot of new classes of medications that have helped. And there's some classes that you might know or you might not know. And I will start with something as simple as the other thing before I jump into that. What I do want to mention is cardiovascular disease and kidney disease go hand in hand. And one of the biggest problems that kidney patients run into is cardiovascular disease. So any kidney patient should make sure that their cardiovascular care, their preventative cardiovascular care or cardiology care is optimized. That is very, very important, whether it be, and I know Kevin Fowler put in something about exercise as well, and I do want to get back to that. But make sure that your cardiovascular care is, and that includes diet and exercise and mental health and mindfulness and all that good stuff. And hopefully we'll address that because that is important. But in the classes of medication, right at the top is a drug called RAS inhibitors, RAAS, and that includes ACE inhibitors or ARBs. And I'll put that in the chat box. And I think Montre just put that in. And there's also the second A in RAS inhibitors is aldosterone. And they are aldosterone antagonist drugs that have been quite useful in decreasing proteinuria in a number of conditions. And some of these drugs are being studied at this point. And the drug that we use quite frequently is spironolactone, but there's also a drug called Kerendia that goes by the name of finerenone that is an MRA. And there is studies going on for non-diabetic CKD. The second class of drug, which a lot of you probably have seen on TV, because if it's on TV, it's probably important, is drugs like what we call SGLT2 inhibitors. Their generic names is dapagliflozin and AMPA, and they go by names of Farxiga and Jardiance. And they have been transformational in our patients with kidney care. And both of them had studies. DAPA, which is Farxiga, had the DAPA CKD, in which 1/3 of the patients were non-diabetic. By the way, these are diabetes medications, or at least they started off with. And AMPA kidney that came after that, half of the patients were non-diabetic. I'm not saying that the FSGS was the primary group over there, but they were non-diabetic kidney patients, and the results were transformational. And the other thing about both classes of drugs that I've mentioned, they not only impact kidney disease, but they also have impact on cardiovascular disease burden. So that's very, very critical. Like I said, every kidney patient should think about not just kidney disease, but cardiovascular disease. And that's what gets them in real trouble. And then we already spoke about aldosterone antagonists. More data needs to come out for non-diabetic, but it's a very, very promising. It's an old class of drug, but the newer drugs are coming. And the fourth one, which probably have heard a lot, is right now the GLP-1 receptor agonist. We have Manjaros and Ozempics and all that stuff, and they have been shown to be quite impactful in our diabetic patients, but they are also looking at non-diabetic. Now, obesity or overweight is one of the factors that can lead to FSGS, and that's something that this class of drug will also be very helpful. So, Dr. Campbell, I think this is a very important question, which we call foundational therapy, right?
Right.
So I would love to hear what you have to say as well.
No, absolutely. I definitely agree that foundational therapy important for patients with proteinuria kidney disease across the spectrum, right? But then, there are specific approaches that will be appropriate depending on what the real cause of FSGS is, right? So there are some rare genetic conditions, for example, that are associated with coenzyme Q mutations, right? Where patients respond really well to supplementation with coenzyme Q supplements. And I think, again, that's one example of a precision-based approach. There are clinical trials that are enrolling patients on the basis of the genetic testing result, for targets like APOL1 and TRPC6, for example, right? So really entering the era of precision medicine in this space. We talked about some of the immunologic etiologies, right? And it's conceivable that we're going to be able to measure an antibody and offer targeted therapy and track the level of the antibody as a part of that treatment response, the way we do for conditions like membranous nephropathy. But again, that's aspirational. As of now, we offer immunosuppression, right, to patients with what we consider to be immunologic underpinnings in that primer FSGS as we think of it now, right? So typically we're using steroids, calcineurin inhibitors, mycophenolate, mofetil, agents like that as a part of our treatment regimen. But these are, again, repurposed drugs developed for other clinical indications, not specific for FSGS. And we really need to do better. And this is where clinical trials come in, where there's a big unmet need that hopefully will be filled in the years ahead. But again, as we went back to earlier, having the diagnosis of FSGS doesn't tell you much about what the underlying cause is. And that's really important to define when we're going to really make a decision on what the best treatment course will be.
Yeah. And Montrez, I just want to piggyback on what Dr. Campbell said, just to highlight just a couple of points that he made. that once again, the diagnosis is critical. What's causing the FSGS, right? FSGS is a pattern of injury that you see on a biopsy. What's causing it, and that will decide what treatment you get. There is a question that came up, which I do want to answer because that's very important. I think we're a bit short of time. Is from Rihanna Sullivan. And her question was, how do we ensure that the rapid progress in drug development isn't just in journals, but actually reaches patient and especially in the under-resourced or underrepresented communities? I think, Rihanna, that's a very, very, very good point. And it's not just about the underrepresented and underserved, which is actually quite important. But if you think even communities that are represented well, the trickle down doesn't happen. We have the basic science research, we have the guidelines, and then we have really what happens. And I think the patient's voice is so important that the patients will need to speak up, that we need these treatments, and what we call in Dr. Campbell's and my lingo is guideline directed medical therapies, right? Evidence-based medical therapies, and that should be practiced, and those need to be implemented. So patient's voice is very critical, and that's where I personally think that organization like NephCure is very important. I know there's going to be a Hill Day coming up soon in July, Montrez.
Correct.
They need to hear. I mean, we need more research here, and we need all of you to speak up. That we have limited resources. Where do those resources go will depend upon how much importance is given to those. So your voice is very important to hear that. I don't know if Dr. Campbell wants to say it, because this is research. Funding is so important.
Yeah. No, that's absolutely crucial. I mean, you talked about it earlier, Dr. Rastogi, about the issue we have with low rates of detection of kidney disease in general, right? We're in a situation where 40% of patients start dialysis in the US without getting regular nephrology care, which is an astronomically high number, right?
Yes.
And so we need to identify patients with conditions like FSGS much earlier in the disease course so that we can slow progression and not really have to rely on dialysis or kidney transplantation, right? When things become too late. So, there's a whole field of implementation science, right? How you get from approved agents to the folks who really would benefit from them. And that's the second step, right? Early on, we're focusing right now for this condition on the drug development space, because again, there's no approved therapy. So it starts there, and then getting those agents that are approved and are shown to be safe and effective to the patients who would need them the most and would benefit from them the most is really an essential next step.
Yeah. And then just going back to, the early diagnosis, Dr. Campbell, that is so critical. Because what is FSGS at the end? And I think you described that, Dr. Campbell, is scarring, right? That's basically what it is. And if there's scar, at this point, we don't have anything that will reverse that scar. So our job is to prevent the scarring from happening in the first place. And for that, you need early diagnosis. But the tricky part over here is, and this is where the underserved community really comes in, and should be our focus. The tricky part of any kidney disease, for that matter, it's not just FSGS, it's silent. It does not cause symptoms. 9 out of 10 people who have kidney disease don't know that they have kidney disease. And we had a float in our Rose Parade this year, and it takes two. It takes a simple urine test and a simple blood test to identify a good portion of these patients. So for our audience today, looks like a good portion of them already have a diagnosis of FSGS, but for their family members who don't have a diagnosis, make sure that they get, at the minimum, annual urine test and blood test. And going back to Dr. Campbell, the earlier we can diagnose these conditions, the better results we'll have. And the second point that I know we are a bit short on time is precision medicine. So there are medications like steroids that are, they'll bomb everything, right? And in the hope that they'll also, take care of the kidney. But when we get more precise medicine, and that's what the beauty of the more recent trials is, that they will have hopefully minimal adverse events and maximum efficacy. So that's what the future is.
So I'm seeing some questions, a few. Like I said, you all, we have 100 people in the chat, which I'm so happy about. I think at NephCure we are gleaming because this is probably the most active chat I've seen ever. This is my umpteenth town hall, but I do want to get some of these key questions out. If your question hasn't been answered and you really need to be answered, please email me. My email's on my name right here, as well as I put in the chat a few times. You can also go to nephcure.org and email us there as well. And either I'll connect you with someone within internal to NephCure or a specialist like Dr. Rastogi or Dr. Campbell. I can get the answers from them. So please know if we end this and your question hasn't been answered, please know that it will be answered if you just reach out. So a few things. Has anyone investigated the interplay between gout and FSGS? That's come up a few times. And also, if someone responds well to immunologic agents, does that mean it's less likely to be genetic, like Rituxan? So, Dr.
Right.
Stogie, you want to take the gout one, and Dr. Campbell, you want to take the other?
Yeah, that sounds good. Yeah.
Yeah. But Dr. Campbell, you started answering, you can answer, then I'll take the next one.
I was gonna say the immunologic question, right? We know that when patients have a genetic etiology for FSGS or nephrotic syndrome, they're less likely to respond to immunosuppression, to steroids, to calcineurin inhibitors. There have been a number of studies all over the world showing that. So flipping it around, right? If somebody responds very well to immunologic agents, less likely to be genetic. But again, in real life, we do have to really be objective and we would not assume that it's not genetic just because there's a response to immunologic. There are some variants like APOL1 where it's not too clear where there's an association, not disease causing, so they're disease modifying genes. So it's not always black and white. It can be very gray.
Right.
And so this is why a thorough workup and an appropriate consideration of all the options may be important. Just a word on genetic etiologies, though, they're much less likely to recur post-transplant. And that again has been shown in a number of series across the world, more recently with the UK radar and Neptune and so on. So with the genetic etiologies, the recurrence risk of disease post-transplant is lower.
Yeah. No, I agree with you, Dr. Campbell, completely. Genetic causes, they don't not depend upon what's causing it as well. But if there is condition like Alports and Fabry's and all those hopefully will not be coming back. And uric acid and FSGS or uric acid and kidney disease is a very interesting relationship, and it's really the one causing the other and a vicious cycle. Uric acid in high doses and unfavorable conditions, and I'll say unfavorable because there are conditions, we can have uric acid of 10 and we might not have any manifestations, as opposed to other that might have a uric acid of 7 and have uncrossed. So in the unfavorable setting, uric acid is a toxin and can cause damage, and anything that causes damage to the kidneys can lead to scarring. And as I mentioned, FSGS is a form of scarring. So there is some connection over there. And then when you have kidney disease, your capacity to eliminate uric acid can also get limited. So that can worsen. So it becomes a vicious cycle. Now, what we do know, we need to treat gout, obviously, because that's very painful. And if that is the case, then we, at least in our practice, will keep the uric acid under control with medications like allopurinol. And that's what our practice is, and dietary changes as well. But one of the things that I do want to point out that always try to look for the underlying cause of FSGS, because the treatments that are coming up, including the genetics and stuff, it will really depend upon the right diagnosis. So that's very important.
Thank you, Dr. Rastogi. We're gonna play that. We're gonna do that. We're gonna do that same thing again. That worked well. So Dr. Campbell, I want you to talk a little bit about biopsy and does it hurt and what does that look like? Does it stay overnight, same day surgery? And then Dr. Rastogi, with your work in APOL1, it'd be nice to hear you discuss has anyone identified the APOL1 gene as the cause of their FSGS and more specifically nephrotic syndrome? I know that answer, thank goodness for Dr. Gibson, but Dr. Rastogi, you discussing, has anyone identified that as a cause of FSGS, of their FSGS or nephrotic syndrome? And that's APOL1 gene. So Dr. Campbell, starting with you in biopsy.
Okay.
Sure, yeah. So I'll start off. So with the kidney biopsy, it's usually, and again, every center is different, but in most centers, it's done under local anesthesia. So
Yeah.
really lidocaine numbing that area up really well before the biopsy needle goes in. And it should really be more pressure rather than pain if that
Yeah.
numbing is done really, really well. And of course, a lot of this will be operator dependent, but it's again a largely well-tolerated procedure. The risk of major complications less than 1%. And I think it's a nephrologist or an interventional radiologist who would be doing it under imaging guidance. A long time ago, those were done sometimes a bit blind or just based on a localization of where the kidney is. But now under real time, you're getting imaging guidance with, again, the area being numbed up very well. So it really should not be painful. In fact, significant pain after the biopsy is a concern, right? And something where we'd be concerned about a major complication. So, I think they're a lot safer now as procedural, pathways have improved.
Yeah. I agree. And I just want to piggyback on what Dr. Campbell said about biopsy, and then I'll answer the question,
Sure.
Montrez, that you asked. The kidney biopsy in the right setting has I mean, there's always a risk, but has been quite low. So we can't say it's zero, but in the right setting and the right guidance, it could be done. And always talk to your provider. We talk to them what the risk for at UCL Health. It's done under IR guidance, so it's an interventional radiologist who do that, and they do a wonderful job. But can there be complications? It depends upon the body habitus. If there's massive obesity, then the needle will have to go deeper. All those kind of things can, if there are risk factors for bleeding. So all those things should be looked into by your nephrologist with the person who's doing that. But in the right setting, the risks are quite low. And Montrez, I probably need to jump off soon after that. I apologize.
Sure.
But I do want to answer the question about the ApoL1. So ApoL1 is quite interesting. I do want to give a bit of a history. We always knew that patients of African descent, now this is not African Americans, the key word is African descent, because there could be Afro-Caribbeans, there could be Hispanics who have African descent as well, right? So the key word is African descent, and the recent migration out of West Africa, which, the term is used 7,000 years. So the ApoL1 gene actually is thought to be a protective gene, just like sickle cell was for malaria. This is for sleeping sickness. So it was a protective gene in that setting, but now in other settings, it actually can cause damage. And we knew that patients of African descent at higher risk, but we couldn't make the genetic. When multiple family members have the disease, we always think about genetics. So that was something that we had been thinking about. And then came along ApoL1, and thought was that is connected to a lot of things. It's not just FSGS, it's hypertensive nephropathy, high VAN, which is in age as well. So there are multiple connections between the ApoL1 and things that can happen with the kidneys. And there are risk alleles, the risk variants when you do the genetic testing. It's actually a part of Natera testing, but you can also get the ApoL1 testing by itself as well. And if you have the risk variants, you're at higher risk. And actually, we started testing for ApoL1 way back in 2016, 17, when it was not common practice. And if the kidney donors had high risk alleles and they were high risk donors, then we would say that you probably should not donate your kidney because they're at risk. This is a very active area of research. A lot of drugs are being looked at, and it's very, very interesting. But I do want to be wary of one point, and I think Dr. Campbell did mention that don't get blindsided, just by what the test is coming in. And I'll tell you a case that we had. The patient came in and was going to get enrolled in the ApoL1 studies and tested positive for ApoL1 because it was a very targeted testing. And I saw the patient because we were enrolling in the study, and I said, something's not adding up. His left ventricle was massive. I mean, it and multiple family members and the genetic, family tree. We did the broad panel testing on him, and he came back to have Fabry disease as well. And that was the prime driver. So once again, I just want to point out the correct diagnosis is important. Can ApoL1 be contributing? Sure, it can be contributing. but one of the prime drivers for him was Fabry, which also presents, by the way, when it's advanced as FSGS. So does ApoL1. So does Alport, right? So all these things are important. So those are my 2 cents on that. And I'm sure Dr. Campbell has a lot more to do. But Montrez, I will need to jump off if that's
Thank you
okay.
so much.
You have my email address. And thank you, Dr. Campbell. And thank you, everybody.
Absolutely.
Thanks, Jamila. And
I'll be
Montrez, it's
bothering you
always
soon.
good to
Don't
work
worry,
with you.
Dr. Rastogi. I'll be emailing you like crazy as always. All 4 of your emails.
And thank you. Thank you so much. And happy
Okay.
FSGS Day. Happy
Same to you, Dr.
FSGS Day.
Rastogi.
Okay.
Dr. Campbell,
Thank you.
I do have a few more for you. And one of the things I
Sure.
think it keeps coming up is most important.
Yeah.
I thank you, Jeanette, for this. Is there have been several questions noting primary and secondary FSGS. Can you give us a quick explanation of the the difference between the two?
Yeah, and I think it's become confusing with the terminology because, as Jeanette pointed out, Daniel pointed out actually that primary used to be called idiopathic. That's when I was in medical school and residency. That's what it was called, where we didn't know the etiology. But as science has evolved, the most recent classification, according to our practice guidelines, actually separates primary from secondary from genetic. Those are actually 3 different buckets, if you will. So primary now is considered immunologic, right? And it's like an antibody mediated, if you will, like an autoimmune condition, right? And it's usually a more aggressive form, higher levels of protein in the urine, a lot of swelling, edema, cholesterol levels being high in the blood. That's really the fulminant, overt immunologic etiology, which is not the majority of cases. Secondary is where you have an identifiable secondary cause. So again, some of the examples are there, diabetes, the hypertension associated, viral infections, some medications, etc. Genetic is its own bucket now, and that would be when you have these disease-causing genes. As I said, we've identified 60 plus of them that are associated with this condition. And then there's a fourth, bucket with undetermined cause. I guess that's the new idiopathic, lingo to use. But so there are, again, 4 different types of FSGS according to our most recent practice guidelines: primary, secondary, genetic, and undetermined cause.
Thank you so much. Thank you so much.
Sure.
Also, one other one I really, really wanted you to ask. Also, thank you, Lauren Eva, for sharing that. Also, big shout out to all of our kidney warriors, our NephCure family, the Daniel Holmes in the chat, Daniel Cavini, as well as so many others. Shannon Moray, they're sharing our NephCure resources. It's amazing to see. Thank you so much for helping everyone in the chat. And please feel free to email me as well if you have any questions so I can get you to the right person, rather internal to NephCure or external. We can for sure help you. So please feel free to email or contact us at info@nephcure.org. Also, can patients have mild version of FSGS all life long or the opposite as well? Or there's no such pattern on the nephrotic syndrome symptoms? Trying to make sure I understood that right.
So,
You want to answer that?
sorry, what was the question? Oh, can patients have mild versions? Yeah, I mean, I guess the question is really, can patients have lower levels of proteinuria, where I think Jamaica just dropped off.
He'll be back, I think.
Can patients have lower levels of proteinuria without progression, right, towards end-stage kidney disease, or can it be the opposite, where there's no FSGS pattern on the nephrotic syndrome symptoms? And again, we can see a variety of clinical presentations, right? Some patients don't progress, right? There are patients with lower levels of proteinuria, and we know the cell of interest that's targeted, right? In FSGS, it's called a podocyte. And it's really the number of cells that you lose correlates with how severe the disease is. And, in our preclinical or animal models at the lab bench, we can really correlate the number of these cells that are lost through injury with how severe the disease is. And we believe this happens in patients as well. So it really depends on how severe the injury is to these cells in the kidneys, and that will determine how rapidly patients will progress or whether they progress at all. And again, we talked about identifying patients early, because if we identify folks early, we can intervene, hopefully, right, with the right medications to slow disease progression. And even with foundational therapy, as Dr. Rastogi mentioned, right, some of these RAS inhibitors, SGLT inhibitors, and so on, there are some approaches that can be effective in slowing progression.
Thank you so much. Thank you so much, Dr. Campbell. Before we get on to Jamaica, who just rejoined us, thank you so much, Jamaica. Would you like to give any general oversight to what's on the horizon as far as treatment options, Dr. Campbell? Any general information about treatment options that are maybe not
Right.
FDA approved yet, but are hopefully coming down the pipeline, and
Right.
we really hope that they get approved.
No, absolutely. I think through a lot of great work NephCure has done, we are seeing a path now where we are able to soon define what success in clinical trials would look like for drug approvals. That framework for approving new agents really didn't exist for FSGS in the way that it did for IgA nephropathy and some of the other conditions that have seen a lot of new options for patients blossom over the last several years. So it started really with that foundational work, right, by patient advocacy organizations. And as a result, we're seeing an uptick in a number of clinical trials that are planned or are ongoing and recruiting. And the hope is that we will have FSGS approved agents within the next year. There have been some studies that have shown efficacy, right, in proteinuria reduction, thinking about agents like sparsentan, and again, a number of other agents are in phase 2, phase 3 studies are also ongoing for patients with the different subtypes, right, of FSGS, particularly the primary genetic etiology. So again, there is more hope now than there certainly was even a year ago for getting new effective treatments for patients with FSGS.
Thank you so much. Thank you so much, Dr. Campbell. New treatments are definitely on the horizon. Thank you for highlighting that, Lauren. We're so excited. FSGS, I've been saying lately, I'm talking to 3 or 4 patients now, almost every other day, and FSGS is finally getting its time in the sun. So long awaited, but well overdue. You all deserve targeted treatments, and we're so excited that we're so much closer to a cure. So we're very excited about what's to come. Please know that NephCure will be up to date with everything. So please register for our email listing. We will be ensuring that it's always publicized on our website, as well as Daniel did a great job of posting the link to our support group. We have an adult support group that meets this Thursday, and our parent support group meets actually Monday. So look on nephcure.org, look under support. You'll see our support groups there. Please register for them. Thank you so much, Dr. Campbell, for everything you do for NephCure, not just tonight, but being on our board of directors and everything you contribute to us, and allowing me to bug you to come to our screening events and do that and help me at record rate do urinalysis testing kits. We're over 170 men. So thank you so much, Dr. Campbell, for everything you do for NephCure.
My pleasure. Thanks again. Really a great event.
Thank you. Now, Jamaica.
Hi, sorry about that. My power went out. It is storming.
We're both in Atlanta, Jamaica. You know, I understand you. We're dealing with the rain. I'm dealing with the rain same time. So, Jamaica, you're an FSGS patient. Can you tell us a little about your background? Like, when were you diagnosed? How did you find out you had FSGS?
So I was diagnosed when I was like 5 or 6 years old. So that would have been about 25 years ago. I just turned 31. So it kind of just started. One day I woke up, my eyes were puffy, everything was swollen, and we had been doing yard work like the weekend prior. So everybody just thought it was just allergies and kind of was just like um, medicine.
You're
That
going in and
didn't
out a
work.
little
Over
bit
time,
there,
I just continued
unfortunately.
to swell. And at the time, can you hear me?
Yeah, it's going in and out. Your connection's a little weak because of this beautiful Atlanta rain that we're getting.
Sorry.
No, you're fine. You're fine. You can try again. You may want to turn your screen off. It may be easier. It usually
So
gives you better connection if you turn your screen off.
okay.
Go ahead.
What about now?
That's better.
Can you hear me better?
Yeah, we learned all the tricks at
Okay.
Netflix.
So yeah,
Yeah.
so I was just saying like yeah. Everybody just assumed that it could possibly be allergies, but after allergy medicines didn't work, then everybody kind of got a little more concerned, like, okay, it's got to be something else. Nobody really knew what it was for a long time. I went to several different pediatricians and doctors. I went to Emory and kind of just a bunch of different places. And I think that the biggest thing at the time was that my family was very open with me, even with me being that young, with like, hey, you're sick, you don't know what's going on. So they allowed me to listen to the conversations with the doctors and the nurses. And there wasn't much on the internet then, but I remember like, my mom would try to find things and educate me on it so that I could understand what happened. It wasn't until I went to Augusta to the Children's Hospital there with the pediatric nephrologist where I actually got my diagnosis. That probably took about a year worth of, kind of just trial and error trying to figure out what was going on. So from there, multiple relapses, multiple medications I've tried, just cyclosporin, Cellcip, tacrolimus, just about everything. Prednisone, of course, which has really been the only thing that has helped even after all these years.
I think we lost. I think we lost our dear Jamaica. Jamaica, I will circle back to you. I definitely think it's definitely due time, and I think our marketing team would love for you to share your journey with FSGS. But Jamaica, if you can hear me, please know that I'll circle back to you and we'll definitely find a time because she has such a compelling story, as well as one that shows a full, broad view of the patient journey and how she's moved from being in a very vulnerable state to now becoming a patient advocate. So thank you so much, Jamaica. Sorry about this Atlanta storming. We had such great weather last week, and then of course tonight it does this. But in the interim, I really want to share our new NephCure clinical trial matching tool. This is so exciting, so innovative, and we are so happy to relaunch our clinical trial matching tool, which will be available June 16th. We are so very excited about it. So I'm going to share a slide that you all can see. And it's our new clinical trial tool. Like I said, it'll be available on June 16th. So next Monday, this will go live. Thank God, thank goodness for our marketing team, as well as our PSC department, Britta, Kelsey, Matthew, as well as Hillary, in more particular, when it comes to website design, and Kylie, their fearless leader, as well as the rest of our marketing team who's made this rollout possible. But next week, we're launching our updated clinical trial matching tool. You can use the matching tool you can easily find clinical trials that match your needs by filtering your location, diagnosis, and other important details. You can download a personalized PDF list of clinical trials that you may be a good fit for, as well as submit your interest directly to the clinical trial coordinator. They'll reach out to you personally to follow up. Also, you can scan this QR code here to find your match. So this will be going live next week, next Monday on our website. This is so amazing. NephCure is, I may be biased, but we're one of one in doing this. This is very exciting. We're very excited to have this roll out just because the importance of clinical trials are becoming more present than ever. And you all participating in them. I've gotten so many requests about participation in clinical trials. Also, we have a great Associate Director of Patient Education here, Brittany Paris, who's done a great job. When the site does not reach out to you, Brittany's on the money and matching and making sure that you get in contact with. So this will hopefully assist with that. And this is a promising tool that we are more than confident in. There may be glitches in the very beginning because it's going to be a new tool, but with our amazing marketing team backing it, we are without doubt that it's going to be innovative in this design. So June 16th, Monday, the clinical trial tool on NephCure, clinical trial matching tool will go live. So please, please, please tune in, set an alarm, do whatever you need to do. Make sure you log into NephCure.org and go review our clinical trial matching tool. If you have any questions about it, please email us at info@nephcure.org, and we'll ensure that we get you assistance with it, just in case there's a glitch or anything goes different. But you can see a big scope of it here, a little scope of it on the right side. If you look here, what is your diagnosis? Have you ever had a kidney transplant? This basically starts to see if you are a good match for a clinical trial, and also matches you with clinical trials, so that you don't have to go through the rigmarole that sometimes comes with that. So hopefully this really gives patients access in quicker time to these clinical trial sites and start them on that journey. Okay? Also, I really want to highlight to Imante Elkenberger. Imante did a great job. He's our marketing coordinator. Once again, under Kylie's full fearless leadership, she has gifted us with Imante. And Imante was really responsible for the recruitment of this town hall. This is by far the most successful town hall we have ever had, and we are so impressed by it. Jamaica, we know we didn't get to hear a whole lot of your story because of our amazing Atlanta Southeast weather. But I will connect you with our marketing team, because I really think that they would love to hear you, and I know that they would love to hear you, and we'd love to do something with you, so that you can truly enlighten everyone on your journey, which is so relatable. And to everyone else, this recording will be available on our YouTube, as well as our NephCure.org site. Look out once again for our clinical trial matching tool. And once again, thank you to not only Dr. Radogi, but also Dr. Campbell and all his work, Jamaica Webb and her journey and her commitment to sharing her journey. And we're going to make an advocate out of you, and you're going to be exalted. I'm so excited to work with you, Jamaica, because I love you dearly, and you know that. And to all that joined tonight, once again, if you have any questions that were not answered, I know that it was a lot. So if you have any questions that were not answered, please reach out to us at info@nephcure.org, or you can email me directly. It's on my name right here, Montrez Lucas at mlucas@nephcure.org, and I will ensure that we get you those answers and you get linked to the right people to answer those questions. Thank you so much for everything, you all, and good night.
Bye.
Thank you. Good night.
Take care. Bye.